Good day, my name is Nicole Marie Arellano and this is my video demonstration on endotracheal intubation. The case is a 25-year-old male policeman who sustained multiple gunshot wounds at the abdominal area while apprehending a riot incident. His vital signs are blood pressure of 70/40 mmHg, heart rate at 130 beats per minute, respiratory rate at 30 counts per minute, temperature of 36 degrees Celsius, and oxygen saturation at 90%. His GCS is 8 and he is scheduled for emergency exploratory laparotomy. Since we don't know the COVID status of the patient, we have to follow recommendations for intubation during the pandemic, such as upgrading mask to N95, wearing a fluid-resistant gown, gloves and face shield, using a negative pressure isolation room, using a video laryngoscope if present, and using rapid sequence intubation. The patient is indicated for rapid sequence intubation since he has hemodynamic instability, increased respiratory rate, decreased oxygen saturation, and has GCS 8. For the materials needed, the mnemonic MAIDS is used. M for monitors such as cardiac monitors and pulse oximeters, which are used to check for the circulation and oxygenation status of the patient. A for airway equipment such as bag valve mask, laryngoscope, endotracheal tube, stethoscope, as well as oropharyngeal, nasopharyngeal, and laryngeal airways. I for IV fluids, which are given for resuscitation and for establishing the route of drug administration. D for drugs. For the induction agent, etomidate is preferred since it is the drug of choice for patients who are unstable. The recommended dose is 0.2 to 0.4 milligrams per kilogram IV. And for the muscle relaxant, rocuronium with a recommended dose of 0.45 to 1.2 milligrams per kilogram IV. And S for suction catheter to remove secretions that may obstruct the view. For the equipments needed to be on the intubation tray, the mnemonic SALT PS is used. S for suction, A for airway, L for laryngoscope, T for tube or endotracheal tube, P for plaster, and S for stethoscope. Next is patient assessment, in which the mnemonic lemon is used. Look externally for any signs of difficult intubation, such as short neck, small mouth opening, and jaw abnormalities. Evaluate by using the 3-3-2 rule. Can the patient fit 3 fingers between the incisors? Is the mandible length 3 fingers from the mentum to the hyoid bone? Is the distance from the hyoid to the thyroid 2 fingers? Mallampati score is then checked, in which the higher the class, the more difficult the intubation would be. Check for any obstruction such as trauma, hematomas, or tonsillar abscess. Lastly, check for neck mobility if there is any limitation. The proper positioning of the patient is by flexing the neck and extending the head. By putting a towel underneath the head, the sniffing position is achieved. First, suction any pulled secretions. The head tilt chin lift is then used to open the airway of an unconscious patient as it causes anterior displacement of the tongue. A bag valve mask is then used to pre-oxygenate the patient to replace the nitrogen volume in the lungs with oxygen to provide an apneic oxygen reservoir. To tightly seal the mask, use the EC clamp, wherein the thumb and index finger forms a letter C around the mask, applying downward pressure, and the remaining 3 fingers form a letter E on the jaw of the patient for upward displacement of the mandible. An oropharyngeal airway may be inserted if chest rise is not observed, then the bag valve mask is attached again. Open the mouth fully using the scissors technique. Hold the laryngoscope with the left hand and enter at the right corner of the mouth, then sweep the tongue to the left. Move towards the vallecula to visualize the glottis opening. A 7.5 mm in diameter endotracheal tube is used for this patient. Introduce the tube at the right corner of the mouth. The tip of the tube must pass through the glottis opening, then advance 2 cm until properly in place. Remove the laryngoscope. Inflate the balloon with air using a 10 cc syringe. Remove the stylet and connect the tube to a breathing circuit or a bag valve mask. Auscultate the lungs for equal breath sounds and the epigastrium for absence of gurgling sounds, as well as check for the chest rise to confirm the placement of the endotracheal tube. Secure the tube with plaster at the right corner of the mouth. An oropharyngeal airway is then inserted as a bite block to protect the endotracheal tube. That ends my video demonstration on endotracheal intubation. Thank you.